Can you summarise like the history, like what's happened since,
So,
and when we did it? And
so we have seen her probably month and a half
About the
before.
9th of December, she
And
suddenly
we
stopped walking while we
She
were out.
stopped walking on after when she was on a walk. She had an injury, we thought, but we were not 100% sure what it is. I had a suspicion that it might be cruciate ligament rupture, and we have tried to stabilize it with medication.
yeah,
But then clients came back.
that's right. We had that chat, didn't we?
Yeah.
So
she came
she's
back
been
and
on
she has
on
been
rest the entire time. She's a very active dog,
Mm.
but she's been resting and she's choosing to rest.
Okay. Oh, okay, that's
a
good.
lot.
That's good.
She
When
hasn't
she's
been
out,
able
she chooses to
She
walk.
is preserving the leg.
But
And
she
when
just sits down so much more than she ever did before, and just sits beside you, not
Okay.
stop. Most
Her behaviour is excellent, actually.
most of
Now,
after she's had a
she
morning
behaves so
work,
well.
after she's had a morning walk, after she's had breakfast and that,
For 5
she
minutes.
basically sits down for most of the day.
Yeah.
If you get up and walk away, she follows you for lunch or whatever, but most of the day she just sits beside you. If you take her into a coffee shop, she sits beside you on the floor or on the seat, you know, so she's mindful. And this morning when I took her out, she had a wee and she stood on her bad leg and had the other leg cocked, and you could see her sort of look like she was going to fall over, but she was swaying left to right as she was having a wee. But she's a couple of times we've given the medication either early or may have even missed it, and a couple of times at night she's gone, when she's been sitting beside me, she's all of a sudden gone, and obviously just in a bit of pain, but then she's gone off to sleep. And she's not missing sleep overnight, fun enough, is she, love?
Didn't miss any sleep, really. She's excellent.
She looked quite sound.
Yeah,
Not there.
but
And she
she seems quite.
putting her foot down, but when you move it around, she doesn't like it.
Yeah, so she's experiencing pain when I examine the stifle joint. Also, there is a little bit of draw, and
Draw.
so when we move,
Oh, so it's too loose.
so the stifle joint or knee joint
Yeah.
of the dog, it comprises of long bones.
Yeah.
And when we move these long bones on top of each other, the amount that I can move the joint is not huge, but she's reacting
Yes.
quite a lot when we do that.
And she almost never shows any sign of pain.
So sometimes the
Yeah.
cruciate ligament is not fully ruptured, and they get damaged. I think in humans they snap quite quickly, and you can see this in footballers.
Yes.
Sometimes it
Yeah.
just goes. He can't walk anymore. That's it. But it actually it's being damaged slowly. So we have these small fibers that are being damaged one by one, and it doesn't have to be fully snapped.
No.
It can be just damaged to the point where it's already causing inflammation. But also there are other areas in the joint that can be damaged, like their menisci. Those are those soft cushions that are supposed to absorb the movement.
So it could be damaged too.
So they can be damaged too, and that can be causing the pain as well. So when we do this procedure, we open the joint and we inspect the joint from the inside.
Mm-hmm.
So we need to open the capsule and look inside. We shave off or remove a little bit of cruciate ligament if it's ruptured or if it's damaged. And then we also inspect the menisci.
Mm-hmm.
If there is damage of the menisci, then we remove part of that as well, because that would be the area that's going to cause further inflammation and pain. So we need to fix that as well.
What are they made of? The menisci? What is it?
Some supportive tissue like cartilage
Yes.
plus
Something like that,
there is I don't know how is it.
Yeah, cartilage.
Something flexible.
I believe it's cartilage. It feels like, it looks like and feels like cartilage when you touch it,
Right.
it's manipulated.
Yeah.
They're like shock absorbers. I think of them as like shock absorbers.
So a
and
bit of give, a bit spongy.
yeah,
spongy.
and they're horseshoe shaped and they
Right.
sit under the condyles, which is the kind of articulating surface. They're basically washers.
Right.
The knee is not a very well, it's probably the worst
Not very well
designed
designed.
joint in the body. That's not fair, but to say that, but because biology is amazing, but still they're, yeah, it's a problematic joint. It's the most commonly kind of problematic joint in the dog, I would say.
So this procedure that we were talking about, I mentioned to you there are two types of procedure.
Yeah.
So one procedure is where we are replacing we are mimicking the cruciate ligament, which is ruptured.
Yeah.
I don't know if you remember last time we were talking about how it's positioned.
Yes.
That there are two cruciate ligaments and they kind of hug each other.
Yeah.
And when we have one missing, which is not pulling forward, then the other one is just pulling backward and it's securing that area. But then if we don't have the one which is pulling the other side, we have this movement of those two big bones on top of each other. And this is obviously, with this movement, there is a chance that we can damage the menisci and there is further damage of that ligament. So when we're doing this procedure, which is called lateral suture or extracapsular suture, we are mimicking the cruciate ligament.
Yeah.
So by applying this prosthetic inside of the joint, we are using the forces that the ligament would use. So we have to obviously position it in a way that would mimic.
Yeah.
The only
How
difference
it
is we are not
movement.
we can't apply it inside of the joint, but we have to do it on the top of the joint. We can't rely on the suture forever, so that's why the first 4 to 6 weeks after the procedure are very important for the dog to be strictly rested, and we need to have just very limited exercise. And obviously we're going to give you a chart of how to exercise, and we're going to have several checks to make sure that we are allowed to do that exercise at that point of time.
Yeah.
What
Several checks with you?
Yes. Yes. So we have to rely on the body's ability to heal. So around that suture, which we apply to mimic the ligament, there is going to be fibrosis happening. So fibrosis will form to actually hold the whole
So it's
weight. So later point, after those 6 weeks, then because we have already this fibrosis which is going to form, we don't have to rely only on the strength of that suture. And sometimes even if the suture fails, it doesn't really matter, because we already have the changes in the joint that are actually helping them maintain the same
Clever,
movement.
isn't it?
It
It's
is,
so
yeah.
clever.
Yeah, but the biology is,
Yeah.
we're just supporting biology,
Yeah.
which is amazing.
Yeah.
Which is why I didn't want to be too mean about the knee joint.
No, I get it. Yeah, no, it is amazing.
It is amazing,
We're using the nature to do its own healing. We just need to obviously support it in the right way. So I mentioned the other procedure,
Yes.
which we don't normally know which procedure is best for the patient until we do
you're
the
in.
X-rays.
Yeah. Oh, okay.
And we were discussing that we don't really have enough funds probably for the other procedure. So I have just done the estimate just to compare it.
Do you want to talk about the difference? Do you know the analogy of the car on the hill? Have you heard me talk about
Yeah, I
that?
don't know how to draw it, but
Do you want me to explain
yeah,
it?
can you do that?
Yeah, so I think we haven't got diagrams, but the condyles of the femur articulate on this thing called the tibial plateau.
Mhm.
Basically, if you imagine a car on a hill, there's two ways of stopping a car going down the hill.
Yeah.
You can either kind of attach a big rope to it and hang on to it,
Yeah.
like a strong man holding onto it, and that's the suture technique. But some dogs have a very exaggerated slope in the back of their knee,
Right.
and those condyles, the cruciate stops the condyles from moving down the slope basically. the other way of dealing with it is to get rid of the hill,
Right.
which is essentially getting rid of the slope.
So,
So they're the two ways.
shave the bone. Or
Well, we actually cut the bone. We cut it in a certain way so that slope is
But
negated.
not inside of the joint, this is done outside of
Yeah.
the joint.
okay.
So when we have this angle here, we're trying to reduce the angle, so then the car, so to speak, or the forces will move here,
Okay.
and it will not have such a,
But the difference in price is.
so,
Well,
the other
the
one
other
is,
thing to talk through, Dragana, is what we talked about last night, which would, do you remember, I
so
was
there are certain things that we have to look at the x-ray in order to be able to say which procedure is better for which condition.
Yeah.
Even if the slope is too high, and if we would probably prefer to do the other procedure, we still can try to do the lateral suture procedure, but there is a difference in expectations of how successful will the surgery be. So if we have the slope, then we will have better outcome of the surgery, which is about, we are looking at 85 to 90%. Is that correct?
So
are those
I'm-
correct numbers?
when you started talking that through, I'm slightly confused by what you said,
Okay.
but you
Can
might not be.
can
You might be
explain?
entirely clear
No,
about what.
I'm now here thinking, oh my god, how are you going to record it? Oh my god, oh my god, I can't think.
What's the
Let me-
difference?
let me take in any
Let me
No,
try.
sorry,
Let me try and
I-
explain. Let me try and explain it how I think about it. I'm sorry. This sounds critical. I'm not trying to be critical, but if I didn't understand what you were saying, then I'm concerned that you might not understand. So, I think the crux of it is that if a dog, and we don't know whether we've got a slope
No.
or not, or we won't know until we've got X-rays.
No.
If we've got an exaggerated slope at the back of the knee, the ideal procedure is to correct the slope.
Yeah.
If they haven't got a slope at the back of the knee, we can just tie a rope, do
Fine.
the suture
Yeah.
technique. Both techniques are pretty successful, but the crux of it is that if we have got a dog with an exaggerated slope,
Yeah.
but we choose to do the suture
Yeah.
technique, we're obviously not doing the optimal procedure.
Yeah.
Okay, so going back to success rates, I would say for a normal lateral suture,
Yeah. No
on
slope.
the car,
Yeah.
we're probably, generally they do really well, probably around 70-75% success rate. Things can go wrong, maybe even up to 80%, but it's an effective, successful technique that we've been doing for like 30, 40, even
Right.
50 years.
Yeah.
If they've got a slope at the back of the knee, it's often the success rate's higher. That it's up to often, I say 85, 90%. So that's the kind of crux of doing the right op, depending on what the pathology is. But obviously now, I think you'll understand that if you do the lateral suture on the dog that has got a really exaggerated slope, then we're not going to put, let's say the lateral suture is around 70-80% successful. Obviously that success rate is going to drop down a bit
Yeah.
because we're not doing the optimal procedure. And it's probably in the order, I've done it a number of times, I've even done it on the Great Dane, I remember, years ago, and that's obviously a really big dog. We're still probably around 60-70%, or let's say, so the success rate does drop a little bit.
How does that translate into her ability to function as a dog?
Yeah, so that's a really good question.
Because 60%, okay,
It
so
doesn't mean much.
it worked a bit over half, but what does that mean?
Yeah, what does that actually mean?
Yeah. She's hungry is why she's so like she's not used to
That's
it.
all.
And the reason I've ended up labouring the point over the years is that early on, I'm going back 20 years, I had a few, in the olden days,
Yeah.
the smaller dogs didn't even get offered the slope correcting technique because dogs around 10, 15 kilos, the vets were saying, well, they wouldn't do it, they don't do it on bigger dogs. But then what happened to me was that I had a few smaller dogs, so we did the same, we did lateral sutures,
Yeah.
and they didn't do that well, and they ended up still needing the slope correcting technique
Yeah.
because the lameness kind of persisted.
Yeah.
But I would say that was a minority. It was the odd dog. It was quite rare.
Yeah.
So in answer to your question, I suppose what I'm saying in a nutshell, and it's a really good question, is that there is a chance, probably in the order of 20, let's say 20 to 30% chance
Yeah.
that we do the lateral suture
Yeah.
and it doesn't work,
Yes.
and it's not successful, and we've still got persistent lameness,
Yes.
and
But does she have still got pain?
so that's another really good question. So a lot of owners will say to me, my dog's lame but he's not in pain. So lameness, if I now put weight on my right leg
Yeah.
and it's sore,
Yeah.
my head goes up, doesn't
Yeah.
it? The reason my head goes up is to take weight off
Yes.
it.
Yeah.
The reason I take weight off it is because it's sore. So
Yeah.
lameness equals pain. Unless, in the very rare situation, you've got a mechanical lameness where you've got...
So your foot's one leg shorter than
Exactly.
the other? Okay.
but that's very rare.
Right.
And we don't see that very much. So in 95% of canine, of dogs, lameness equals pain. So yeah, there is a chance. So the likelihood
So
is...
she could, the worst case scenario is she could end up still in pain and hobbling a bit.
Mm.
So is that your thinking? It's
Yeah,
not going to
because-
happen, it's going to be fine, it's all going to work out beautifully. But if it doesn't go according to plan for some reason, or, you know,
Even with the
There's-
best procedures, and even if we would have done the other procedure, the slope procedure,
Yeah.
which in here it sounds like if they have a slope, that's the best procedure, and it's never 100%.
no, I get
They
that,
can
but
always have
how
a-
might...
Yeah, you're
what
asking
do
for
you do?
realistic
What do you do
expectations.
if it's not better?
So at that stage, the options would be either we continue to manage her symptomatically or conservatively with medication, things like, we're careful with her exercise, she'll probably need to continue on painkillers, like the non-steroidals. We can add in things like Lateral. There's a multitude of different meds that we can
Right.
use to
So it'll
manage
only get
it.
better.
Well, I guess the two options are either managing it like that,
Yeah.
or, as I said, I had a couple of dogs that didn't do very well, and we elected to then do the slope correcting procedure
Yeah.
down the line. I mean, so I suppose if she's got a slope and the ideal procedure is to correct the slope, but we do a lateral suture and she doesn't do very well, we can still salvage it down the line, because she could still potentially have that procedure. But the reason I felt in those cases, the reason I always started to offer it in smaller dogs was because I just felt bad that we put a patient through one op
Yeah.
and then we've had to do another op. So now I just try and be it wasn't that I wasn't being transparent before. We didn't really realise
No.
back 20 years ago, but now we know that.
So, can you please tell me what's the difference in price? Because that's-
the price
we
for
can
the other
either-
one is 4,500.
It's another quid extra.
I'd say you probably want to say up to about 5,000 to give yourself a little. It's always better to slightly overestimate, and then if it comes out less, that's always a bonus. But it is,
Okay.
there is quite a significant difference in cost,
Yeah.
and the reason for
Well, it's
that.
obviously a more complicated.
Yeah, we.
No, we get that. Yeah.
So the first part of the op's the same. We go in the joint and do what we do, but the second part is very different. We go to the inside of the shin bone, the tibia, and we make a cut, and then we stabilise the fracture that we create,
Yeah.
so almost the slope with like a titanium plate and screws and a cage.
Yeah.
So it's
There's a lot more to it.
there's a lot more to it than the first technique.
It's just a question of whether we can afford it, and our
But she
insurance
might-
company won't.
And we might be talking. This may be
All
completely.
theoretical.
Yes,
Yeah.
because she might not have a slope.
Yeah.
You know, we don't know that, do we, at
No.
this stage?
So should we get on and do the X-rays? Is that our next?
So basically, what
I'm
we
getting more
were
and
what
more
we were
anxious.
trying
Oh,
to
yeah.
do here, what
What's
we were trying
making
to
you?
do
What's
here is
making you? Hang on, let's stop a minute. What's making you anxious?
She's stressed and she's hungry and she wants to she wants to do the next thing she's not used to. So I'm getting her.
Yeah, you're picking up
she's
on
probably
that.
getting mine.
No, she's just looking at that food. She
Yeah,
can
she
see
knows
that food,
she
right?
knows the
Yeah.
food's there. Thank you. I just want her to be okay and not and to be able to pay for it. So the best thing seems to be that we just get all the X-rays and then see
See where
what
we're at.
happens.
I think that's really sensible.
Yeah.
I think she's coping in here quite well actually. And as soon as, I think, hopefully as soon as she's left with us, that you know she's in good hands, and then hopefully you can.
She loves it here.
Yeah, she seems okay actually.
She loves Dragana and
So
Yeah.
just to let you know, when I do these ops, when I don't eat until my patient eats. I just have some kind of, I feel bad for them the day we're not able to have breakfast. So I don't have breakfast until they eat. So we eat together. When she wakes up, I will eat with her.
That's so lovely. I know she's in the best place. I really, really do. And I completely trust both of your care and your knowledge. It's just, oh my gosh, I hadn't really considered the chance that it may not be a feasible operation. So I just think we need to get
Find out.
learn,
Yeah.
find out what
Find out what we're dealing with, and
And then discuss.
give you a call
Yeah.
at that point.
Yeah,
So obviously because I wanted to try to cut the cost,
yeah.
that's why we have arranged it as we do the X-rays on the same day.
Yes.
So normally I would do the X-rays before,
Yeah.
so I know what I'm looking at, and we can have the chat and
Yeah.
everything. But because we wanted to cut the cost, we want to do only one anesthesia, and if we can go ahead and do the procedure at the same time, if everything is okay, then we would just do it after we do the X-rays.
Okay, so
But we don't have to do. Let's just
No, we
step
don't
back.
have to do
We'll
it.
step back a minute and say we don't have to do that. So for me, I always try to. I try and do it all on the same day if I can.
Yeah.
But what's far more important is that my owners are completely on board.
Yeah.
So if there's any kind of doubt about that, I'd much rather, short anaesthetic or sedation, get some X-rays. If we have to wake up, have another chat for half an hour to talk it through, I'd always rather do it like that than I'd never want to go ahead with surgery until I'm 100% sure. Yeah, we don't want that.
No, we are.
We're 100%
sure.
sure. It's just for us, we've got money issues because I'm in the real estate industry and it's shit at the moment.
Yeah, absolutely.
So, and we've just moved house. We've moved in with Hills' mother to cut back our living costs. And if it's this quote that happens, we're completely fine with it.
Yeah.
So we've got £3,000 or £2,900 of insurance cover, and we'll make up the difference. We want it to be fixed.
Yes.
Ultimately. As you can see, she's a happy little dog, even though she's in pain, right? Whenever I go home to Australia, she sits there and pines for me. As soon as she sees me on some Zoom call, she's wondering where I am. Right? So,
Yeah.
good chat.
Let's do
It
the
probably,
thing.
it sounds to you like 65% is not a lot, but that's a really good success
Yeah,
rate. It's not,
listen,
it's
No, that's fine.
it's still a good procedure. It's not that
I know we can't do it for a while, but I just, I wanted to get back like she used to go for a run properly. Not a run, but used to
You
go.
should get back
Yeah.
there.
She hates the fact that
run for 2 months.
Yeah.
the fact that we've got a lead on her all the time. We used to take her down to the roughs in Avenue, and she used to love the roughs, right? And then we haven't taken her there because she wants to get off the lead as soon as we get there, right?
Probably, it may take up to 6 months to get off the lead.
That's okay. That's okay. But we're working towards that. Currently, we can't work. It's just no chance I'll let her off the lead. I went up to Meadowbank yesterday and wanted to let her off, but I couldn't.
No, she hasn't been off the lead at all.
Obviously, in older age, they can get arthritis because the moment we have some kind of pathology in the joint, that can, so we might need to give her some medication at some point to be on meds all the time. But this just won't happen to her.
Just want her to feel better, really. That's all.
She's a food addict.
Yeah, she is. Lost a bit more weight, which is good.
Yeah.
That's
Even though she's been sitting around.
Well, because we had problems with her when she was young. She had gall, she had stones in her bladder, and she's on a diet. I can't remember what food she's on. But we're religious about it. We don't want to.
And we're giving her less because she's doing less exercise. Okay, Go and
we
have an
a
X-ray.
plan. Let's get the
Yeah.
X-rays and then.
I don't think you should be upset. Like, she's happy here. She's
No, but
we are
she's our
friends.
baby. She's, you know,
We are friends. She's not, look. She's
Yeah.
jumping around
But
trying
she's quite
to
happy.
ask for
Mm.
attention.
she's just stressed at
Where-
what
She just hasn't
are we
eaten
waiting for? She's not used to just.
And she's gonna know about hunger for another hour maybe.
Yeah.
And she's gonna be under general anesthesia. I'm gonna be suffering from hunger.
How old is she?
7. No,
Seven.
7 next
So
month.
she's only young.
6 years and 11 months.
She's about to start barking at me because when she doesn't get fed, she can't.
Okay. So
So
where?
here we can see, here we can see the muscle difference on this side. So this is the left, which is unaffected leg, and then this one here is the affected leg,
So just show where you see muscle atrophy.
right here on this side.
Yeah. So that quadriceps compared to the other one.
So that would be the
Yeah.
corresponding to the quadriceps muscle
Yeah.
on the X-ray,
Yeah.
and it's nicely visible on this projection. If we want to be, I mean, it's quite visible with the naked eye, but if we want to be very accurate,
You
then
could
we
make
can
it.
measure
Yeah.
from. I think what I have seen previously, people would measure from the bone till the edge, and then
Okay.
same from the bone till the edge, and
So-
compare those. I think it's here somewhere. this
So you
scale.
can another quite objective place to measure is if you go to the greater trochanter and you look at the gluteal musculature covering the greater trochanter and you look at the difference. But
So this area.
yeah, and you're looking to see whether there's more thickness of muscle on the left leg compared to the right. So, it's actually much easier with this dog to look at the quadriceps muscles because I don't think
I
it's.
don't know. These lines are, they are skin, right?
Yeah.
So this would be at the end of our muscle.
Yeah,
So this here,
yeah,
and then we have from here. To
yes.
There.
So there is more on the left, isn't there? So that's a really good place to look as well. And we talked about when you're looking at hind limb or forelimb muscle wastage or atrophy, you want to look at the big muscle group. So top of the leg, so the front legs, you're looking at the scapular muscles, the infra and the supraspinatus, and then with the hind limb, you're looking at the quadriceps and the gluteal muscles. So you're not going to see it over the distal limb at all, really. Oh, this is cool.
I'm not really sure about this fold. So
No.
the line goes like this. So I think we're here somewhere.
I'd measure the quadriceps.
Oh,
I think that's your idea.
0.49 on
Right.
the right, which is
Ah.
affected, and 1.27
Oh, okay.
on the left.
That's really
So
good.
Should we try this one? as
Yeah.
well? So if we try to maybe keep in the same line, sort of, or we can go here where the muscle is the biggest.
Yeah. So what's that? 2 point.
2.37.
Okay. What does that say? 3.
3.04.
Huh. Yeah, that's pretty cool. Do you like
Yes.
the McKee locking suture?
McKee.
Yeah,
Yes.
you like that?
Yes.
Okay,
I think
it's
that
good,
was
isn't
quite-
it?
We have tried something else last time, but I think I quite like the other one. It just looks so neat. And
Yeah.
It's not very bulky and thick
Yeah.
on the top.
Okay. And you've got the ratchet system that you can do with it,
Yeah,
which is quite neat, isn't it? Okay.
I do quite
okay.
like that.
Okay.
Because with the other one, it's quite difficult to let go.
Mhm.
But with this one, if you think it's like too tight, I think it's much easier to kind of work it out and just pull it back, and you can pull the ratchet back and
Mhm.
turn it as
Yeah.
well
So you're going to
without
do,
damaging
yeah.
the suture.
Can you remember how?
No.
You can remember how to do it roughly. Otherwise, I can try and find a diagram. I've probably got it in my
The
phone.
ratchet.
Yeah.
So, because the other side is a loop,
Yeah.
so I need to pull the needle through here backwards and then split
Mhm.
those two ends
That's it.
and then
Yes. Yes. And then
go
not.
around.
And do you remember how you do the
Yeah,
back?
we do like twice or 3 times.
So, yeah, you want to do
So
probably
with the,
2 or
with the
3
ratchet,
times.
when obviously I pull both of these
Yes.
around
Yeah.
and then just pull.
Yeah, like a ratchet system.
Yeah,
Perfect.
pull and then push back, pull, push back,
Yeah. Okay, that's good.
and then go around.
Yep. And approach to the joint. I think you're happy with that now, aren't you?
Yeah, obviously we still need to be careful where we are cutting into fascia lata. And I mean, fascia lata, you said less likely to not have enough space, but mainly the joint capsule we want to be right in the middle.
Yeah, good. So you've got enough
You
joint
told me
capsule to
that
close.
maneuver where we press on the capsule from the back.
Mm-hmm.
So from the caudal aspect, where it kind of pops
Yeah.
to the front, and then you can sort of see the balloon and just go in the middle,
That's good.
and then be happy and awkward about the joint.
And we've got the Stifle Distractor, so you can do a proper meticulous
Oh yes,
examination of the
I am
joint.
a little bit scared of that one. I'm
Fine,
so
I
worried
hope
that
you-
I'm going to damage something.
No, you won't. And then you're going to check the menisci, confirm the cruciate's ruptured. What you're going to, in this size dog, you'll probably suture the joint capsule with what? Do you think?
So joint capsule. So she's 10 kilo. 3 metric. I would
What's that in old money? Is that
So
2
that's
naught?
2 naught.
Yeah.
3 metric, and then I would probably do 3 metric as well for the
Fascia
fascia
lata.
lata
What's type of suture? Like,
type pattern. You mean?
and type?
So we should have the same suture left. I would do the same.
I can't
3
remember.
metric.
I can't remember what you said you were going to use in the joint capsule. So
3 metric.
yeah, but what type of
2
suture?
knot. Oh, PDS.
Okay. So you're going to use PDS in the joint capsule. I don't think it really matters. I mean, you don't technically really need PDS in the joint capsule because it will heal so quickly in like 2 weeks. So PDS obviously lasts for like quite a while. So Monokryl's fine in the joint capsule, but it's not wrong to use PDS. But in the fascia lata, why is it so important that you choose the right material?
Well,
Or what would you use?
so fascia lata is the bit which is the strongest. So we need to.
Yeah, it's strong, but what kind of tissue is it? What's it made of?
Oh, the fibers.
Yeah, like connective tissue.
Yeah.
So how long does it take to heal?
PDS probably starts dissolving within 45 days, I think.
Yeah.
Until 90 days.
And the fascia lata takes longer to heal, doesn't it, than the joint capsule? It takes
So-
the longest of all the tissues that you're going to encounter.
So we need PDS because that dissolves the latest.
Yeah.
So until we need to give that time to fascia lata to actually heal.
Yeah.
And yeah, fascia lata, well, so I can't remember exactly, but I think it takes about 3 weeks.
Yeah, I'm having a mental blank as well. I want to say 8 weeks, 6 to 8 weeks.
Oh, is it 8?
Yeah, I think. I don't think it's 3 weeks. Yeah. So that influences the pattern that you use. Would you use continuous or interrupted?
In fascia lata, I would use interrupted
Because,
because if anything happens, then everything falls apart.
Yeah,
That's
good.
the most
Yeah.
strongest part of
Yeah.
strongest tissue.
perfect.
So we want.
That's perfect. No, that's really good. But To save you time, you can do Cruciate simple interrupted, yeah? So rather than doing like 20 simples, you could do 10 or 8 Cruciates, which is going to,
I mean,
which
I
are perfectly
normally do.
acceptable.
I normally save time on skin because I do intradermal.
Yeah, yeah, but
top layer, so that's quite quick. But yeah, if we're running out of time.
even if you're not, just do Cruciates. You don't need to do simples.
Okay.
Cruciates are perfect.
And joint capsule.
What do you think?
Can I do? Do I do simple or do I do? I mean, no. I think previously I did simple.
Yeah, it heals quite quickly, doesn't it?
But we don't. That's not really. Is that important to have simple interrupted or can we do continuous on the?
What do you think?
Well, previously we have done interrupted.
Okay, I would not personally I'd rarely do interrupted on joint capsule. I normally just do continuous.
Which is why I'm not really sure why we
Okay.
did that.
Don't know. But yeah, continuous is fine.
So first layer continuous, fascia lata, strongest tissue needs to be simple interrupted,
Yeah.
and PDS, and yeah, the skin and subcutaneous tissue we can. I normally use PDS anyways. I'm just used to that.
Okay.
Would you use anything else? Why? I don't know about that. No.
For what? The fascia or?
No, for the skin.
I normally do intradermals and I quite often use staples, but
Okay.
it's kind of down to it's up to you really. I'm less bothered about that.
I'm used to PDS, and I think I'm just gonna do that. But obviously, I'm not gonna use such a thick material.
Oh, what in the intradermal?
Intradermal.
Okay.
I normally use like 2 metric
Okay.
for that size of skin.
I mean, if you're doing intradermal, technically you don't really need PDS. I mean, Monocryl's fine for the same reasons that we talked about with the fascia lot, but it's up to you. I mean, I
don't have such a good experience with Monocryl.
Okay. Oh, it's nice. It handles very similarly. It's easier to handle than PDS, slightly easier.
So previously, the surgeon did.
When we were speaking to the owners, I was saying that the technical side of coaching is really easy. Like teaching you to do like that stuff that we just talked about is pretty simple. The bit that is unquantifiable, unrecognised is the mindset shift. This is the hard part of surgery. It's not actually the technical bit. I can teach the technical bit really quickly, but actually shifting your mindset so that you are calm and collected and not feeling overwhelmed and anxious and stressed, that's actually the key thing.
Yeah, I don't feel stressed. I'm just I already have thoughts of what I have discovered today and what have I learned today extra that I maybe haven't been paying so much attention to it before, and it's just every time I discover something new, and I am a little bit self-critical, so I have expectation from myself to learn everything at the first visit, but it's impossible. So I have to be a bit patient as well myself. So yeah, I think every time when we do the procedure, I'm able to focus on different areas, and like there are stuff now that I feel like entering the joint capsule, which initially scared me. I'm quite confident with that one, so I'm not thinking about it a lot. But now I have other steps that I'm questioning myself and
And I think the actual responsibility of fixing this dog is now starting to weigh on you a little bit more.
Yes.
Is how it feels.
Yes.
I think that's happening because I'm trying to encourage you to do more on your own.
Yes.
And that's
Right.
that. Yeah. So you're starting to feel it.
I feel the pressure now.
You
that
feel the pressure.
I'm responsible.
Well, but I'm not going to let
when
you.
you bring the baby home.
Yeah, but I'm not going to. I'm going to support you. I won't let you make any mistakes.
I know, yes. Which, thank you very much for coming back to look at Barbara.
Yeah,
Which I was worried about. So
Yeah.
that was
I think they want to come through. Yeah. Sitting really nicely. So just bringing the chest up. Could go a bit more, but Dragana's doing a repair of a cruciate ligament rupture. We've taken prelim x-rays which show no evidence of a staphotibial plateau, so we're happy to go ahead and do a lateral suture repair.
so if I go another centimeter?
Yeah. You just want to go as far as you need to in order to locate the patella immediately, don't you?
So patella is here.
To inspect the stifle joint, you need to relocate the patella immediately whilst applying the cruciate distractors into the flex stifle joint so that you can inspect the menisci.
Yes.
Flexing. It's not really exteriorising very well, is it?
No.
So you need to work out why. I'd say you want to see the tension in that tissue.
This one?
Yeah, but go to the proximal. You don't. Yeah, you cut it exactly. You want to extend that, don't you? A little bit better. It's still not great, but you're getting there. You've done all of the. You've done everything on your own, pretty much. I haven't really done anything. I was very tempted not to scrub it. I was very close to not scrubbing in today, so because I thought you were perfectly capable of doing it all on your own. So I really want to do. I want limited input from me.
Okay.
Because you're going to learn a lot more. It's hard, but surgery is a mixture of support and challenge and working out when you need to do which. And I know that you're quite stressed at the moment, but learning kind of takes precedence.
Lateral meniscus.
Good,
From
okay.
what I can see,
Yeah.
it doesn't look like there is damage. But
Okay,
again,
good,
when I
good.
open it more, I should be able to see more.
Apply the cruciate distractors, have the bulk of the instrument on the medial aspect. Exactly. Do you remember? Just so
Yes.
it's out of your way.
Yeah, I was just trying to put this on first.
It's the best you've done so far.
I know, I'm very proud of myself.
Yeah, it's really good.
Yeah,
I want to see.
practical.
I want to see if I can help you get it even better. So you need to
Okay.
watch what I do. So I rarely use RAT2s, but I'm using RAT2s because
Okay.
they're going to hold the tissue.
Okay.
I'm going to release off there. I'm going even deeper than you
Okay.
did. Can you see how deep I'm going?
Yes.
Okay, so we're getting really good. I'm getting even more purchase of the jaws of the cruciate distractors. Now, it may not end up being any better in the end, but we said let's always put the cruciate distractors on the medial aspect, and then I was going to stop you, but I let you carry on when you put the Gelbs in. But I don't know if I'm just being really anal, but I tend to put them here rather than here because I find they're less in my way. Do you think that's
Very
any
good.
different?
Oh yeah, it's much. I can see much more now.
It's a bit more exteriorised, isn't
Yeah.
it? Well, exteriorised is the wrong word, but we've got better exposed, slightly better. But just
better vision.
so making that little tweak by putting those jaws. I mean, you can see they've slipped. You see how they've slipped because I put them under so much pressure. So they still ended up in the same place as yours, but I've probably just put a bit more
But
pressure.
I think also if I would have just opened it slightly more, I think I would have.
Yeah, and that just takes a little bit of bravery because.
Yeah, I'm just a little bit worried about the tissue damage.
And now you're using the proper swabbing technique, which we talked about, which is really good. You could be even more precise. So you grab the corner. If you really want pinpoint precision, you literally just take that. Can you see? So rather than just doing like that, you can just be even more precise with where you're dabbing your swab. Yeah. Because I think you can answer all your own questions by just getting better exposure.
Yes.
But it's still really good. So Dragana's getting into the joint much more easily. It's taking less time, it's less traumatic, she's causing less damage to the tissues. She's able to do an effective arthrotomy. Then she's able to do an effective joint inspection, because she's able to place the cruciate distractors in the right place. You don't have to use cruciate distractors, you can use Hogan's, but anyway. So there's been definite improvement in those two areas, because I think last time Dragana felt a bit despondent after surgery. She felt that she wasn't seeing improvement, but that is evidence of improvement, which is now documented, so you can't really dispute it. Remaining proximal aspect of the joint capsule from the lateral tensor fascia lata, and what she's noticed is that by doing that, one, it makes it much clearer to see the dissection plane, so to see all the joint capsule what needs suturing, but equally importantly, she's now got really good access to the fibella and the femoral ligament. So it's going to make passing the lateral suture round the fibella so much easier.
So this thing here that's moving around,
Yeah.
that's my fibella, right?
Some feel. It's quite hard to feel, isn't it? It's going to be, yeah, it's probably all that tissue in there.
It's like inside of this muscle tissue.
Yeah.
And so I go here, and I should come out somewhere here.
Some feel. Yeah, so try and rock the fibella, but yeah, I'd agree. I'd be going, yeah, like under there, and you can get right under there and come out around it. Yeah, you know what to do. You absolutely know what to do.
Let's see. Yeah, I felt it rocking. I felt it rocking under the needle even.
Absolutely, you
So
are.
I'm just surprised how
Easy
easy I have done it.
Yeah. Are you
Okay.
recording? That's massive progress. That was the thing that you were most.
I'm a genius.
Yeah.
I'm
You get a gold star for that. That's brilliant.
Okay, I have tackled basically two things
You've done the whole thing.
today, which previously I was worried about. Okay.
And if I'd done the op to take the pressure off Dragana, you would have not had those learning opportunities.
No.
So it's worth all the stress, I think.
It is.
I know it's stressful, but it's so worth it. See, so you now don't need me for cruciates. You're pretty
Do
much
I?
there. You're pretty
Do
much
I
there.
not?
Lateral sutures. Next time there's one, I'm not going to be in here. I'll be upstairs,
No.
and I can watch you through the camera from upstairs. And
Well, that's a good idea, because
Yeah.
she just thinks
what I try to do is like gradually wean my get out of theatre. So initially I do it, and then
and she will be just shaking.
then I hold her
very
hand,
easily.
and then now I'm just like on the
That's a-
sidelines. So
that's a
next
good-
time I won't be here.
That's a good technique.
It works really well, and then I make myself redundant, and you'll never see me again. Things to do, but you have to draw the support over time.
Then it will be just on the floor only.
Yeah, so I mean, I'm always in the building until the point where I'm really super confident that a vet can just crack on, and we're pretty close to that now. You know, a couple more, and you're definitely going to be able to do them. You won't. What happens is that you support a colleague.
I think I should be fine.
So in the early stages, you're supportive, and then latterly you're more challenging. So some people do it the other way around, and they're really challenging and critical early on, and that doesn't achieve anything. You just scare the shit out of the person. So you have to be supportive, encouraging, but less so over time, because otherwise the person never becomes independent. So it's simple, really.
Okay, so
Although I find it exhausting to do it, it's so valuable, and someone's got to start doing it somewhere in the profession, because no one's really doing it. And I'm hoping that if I do it, and then I can help others,
okay,
it will
Kira,
encourage other people to do it.
this is where I want to go exactly about.
Yeah, so I just think over time that I want the profession to do more of this. So if I lead by example and then put stuff out in the public domain and publish stuff, and people think it's valuable, then I'm hoping I can find other vets, because because I can't do the whole country or the whole world, but the thing is, to make a big change within the profession, it needs to happen day in, day out in every general practice in the country. And to do that, I need to find, like, I don't know, another 100 vets that are prepared to do what I do. So I've got to train up people to, you know, I just think there's a lot of peripatetic surgeons that could be doing this.
But it would be really amazing if this really catches on, and then you have, like, I don't know, 20 vets, for example, just traveling around the country and teaching other vets to do things.
I think that drill bit is really sharp, so I think it's really important. I just think it's a really important thing that needs to happen, but at the moment no one really understands why it's important. I feel like for the last particularly 10 years, I feel like I'm the only person that really understands the value, the point of doing it. But you know, like sometimes I know that it's the right thing to do. I know it's the way, because I've been doing it for like 20 or 25 years.
Right.
So I know that it works, and it's the only way to do it. I'm not interested in referral stuff because, well, they can do all of this, but I'm interested in upskilling GP vets to do the kind of basic. This is basic orthopaedics. This is nothing fancy. I think all vets should be able.
I think when I see all those older vets, old school vets,
yeah, they'll do
they
it.
always done.
Take it. No, you need to work it out.
So I'm gonna go with the needle that way.
Yeah.
I just want to take this through the other side so I can pull the needle
But
out.
just do it as distally as you can.
Okay.
But I just need to feel. Yeah, look, have a feel where I am now, and you can just push it through. Well, we can stitch up in a minute. This is going to take another 10 minutes.
So hopefully it will last. This is usually.
Right, so you have literally done pretty much all of that on your own. I've given you the odd little tip, but I think what's really interesting is that last time you were really disappointed after the last one that we did, and you felt you were really beating yourself up. And I was saying to you that evening on WhatsApp, you were being too hard on yourself, and you were doing better than you were being really hard, basically.
You were right.
And I was right, wasn't I? Because today you've literally done the whole bloody thing, like literally, and you've actually found it. I think you've surprised yourself at how straightforward it is. I think you're surprised, aren't you, that it's a lot easier? Because in your head it was like you've
Also,
got.
this time, for some reason, that fibella was just there.
Easier.
I could feel it.
But I bet a big part of that is because you dissected off the fascia lata off the fibella, so you could visualise it and really feel it.
But I was able, exactly how you taught me from the beginning, that I'm supposed to feel how it's rocking when the needle is
And then
getting through.
Yeah, it's easy, isn't it? It's not difficult.
Yeah.
So I think this is going to be really. It's going to give you a lot of confidence what we've done today. Yeah, I mean that feels. Oh yeah, that's solid as. That's brilliant. Yeah, that's really good. Maybe in November, December, I asked Dragana for some feedback over the last 6 months, and you were really reluctant to give me any feedback. And actually,
No,
no. But I'm glad that you didn't, because I think now we can do feedback in the last 6 months.
I was also feeling shit about myself after last one.
Were you?
So
yeah, you were, weren't you? But now, it's like we can actually document your progression over a 6 month period. I don't even know how many you've done, but you've done a few, maybe 3 or 4. Not that many, but to be. I've only done, let's say it's 3 or 4, and you're now at the stage where.
Yeah, we have done some TTAs.
I've done TTAs, but to be at the point within a few to get to this point. And no one can ever take it away from you. You've now got this skill for the rest of your life, which I think is quite powerful.
I was expecting that I'm going to have a little bit more, not even confidence, but that I would remember more. Because I think the first one, I did not expect to do much. And then you actually had me do quite a bit. And I was just expecting that I'm going to remember more things from that procedure, and that I'm going to do much more. last time, but not like in the sense that, because you allow me to do everything, but I was just not confident enough to apply GLPs, for example. And today, I think I have cracked it.
Yeah, a few things surprised me today. Actually, in terms of the procedure, you managed to do all of it really well, and it's actually, from a practical point of view, you remember everything. So you have no problems remembering. The bit that surprised me is that you've forgotten things like measuring a joint effusion, like using objective markers like with the metaphysis. That really surprised me. So, but what that highlights is that you're really good at remembering practical stuff, and the slightly more theoretical stuff I need to remember to test you on it more, so that, because clearly it's a lack in my ability. I didn't teach it properly because you didn't, otherwise you would have retained it. So obviously last time I probably thought that you understood it, but I don't think you did fully internalise it. But that's quite normal for learning stuff. But you are very good at remembering the technical processes. Because you've gone through it. Like I said, it's like riding a bike, didn't I? Well, that was like riding a bike. You just did it. But more importantly, what I said to the owners
and
was...
you gave me quite a lot of confidence today, because you know how I felt before the procedure.
I did know how you felt. But also, do you remember I was saying to the owners that the easy bit is the technical skills. The hard bit is the self-belief and the mindset and the confidence. But now you can see what I was saying to the owners is what I've been trying to say to you, that that's the difficult bit, and that only comes from doing it, getting better at it, progressing, dealing with complications, and then you become more confident, and then you get a mindset shift, and then you start doing more difficult surgery, and then you grow as a person. That's kind of what happens. So although you might think it's a technical journey, it's not. It will change you as a person. It actually will change you. So it's super powerful.